Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing you another really fascinating guest involved in creating a better tomorrow for many people out there. Today, we have the honor of being joined by Professor Dr. Alan Widgerow, who is a Division Chief Research for the Center for Tissue Engineering and Adjunct Professor in Plastic Surgery, Department of Plastic Surgery, University of California, Irvine, as well as Chief Scientific Officer and Head of Skincare Science Center of Innovation at Galderma. Professor Widgerow is a plastic surgeon who ran a private practice in South Africa for over 2 decades. Has held various positions both in academic and professional associations, including as the president of the Association of Plastic and Reconstructive Surgery of South Africa. He is extensively published. He relocated to Irvine, California back in 2009 to pursue various interests in medical devices, cosmeceuticals, wound care, still plays a very active role in academic medicine worldwide, was appointed faculty at UC Irvine Plastic Surgery in 2012, was a full adjunct professor and director of the Center for Tissue Engineering, and in 2021 was appointed as a division chief of research. He has developed and licensed multiple products in both the U.S. and South Africa markets, has been very active on the business side as well, involved in Alaskan Skincare, which was ultimately acquired by Galderma, an early stage startup in terms of professional skincare products. And as to date, currently at the Skin Science Center for Innovation at Galderma is involved in everything from aesthetic work, prescription and consumer products in the skin science research and development space. A lot of really interesting topics to get into today. Honored to have with us Professor Dr. Alan Widgerow. Thank you so much for taking time to come on the show today.
Thank you, Ira. It's a pleasure to be here with you, and all accurate. So great background research there.
No, it's a great journey you've been on. I'm looking forward to getting into a lot of these topics. But like most episodes we do, I would love to start off by handing you the floor for a little bit, just to talk a little bit more about your background. As I mentioned, you started off in plastic surgery, and I took a look at some of your sort of early publications, and you were doing a little more than plastic surgery, some very complex cases. I saw papers on tummy tucks involving people that had colonostomies, aesthetic procedures in mentally challenged patients, some very early in life keloid work. Talk a little bit about your background, a little bit about why you got involved in plastic surgery in general, and a little bit of the early days, if you would.
Yeah, so absolutely. And again, Ira, you've done your homework there. I've almost forgotten about all those, but essentially, as a plastic surgeon, firstly, the decision to do plastic surgery is a unique one for different personalities. You have to be a sort of A-type and a compulsive kind of personality where everything has to be sort of perfect and lined up and straight. But the beautiful part of it is it's this amalgamation of creativity and science, so that if one has got a creative bent, which most of us as plastic surgeons do, so I used to do a lot of sculpting and different areas of artistic side that we work with your hands. And then you look at that and you combine the aesthetics with the science and with medicine, and it becomes a beautiful sort of perfect storm of different areas together. And I think from that perspective, it probably gives us the capacity to think laterally, because the position that I have now, I couldn't have even thought about or planned. It's just such a hybrid of so many different things. including, academics, including business, including really good levels of different levels of science. So from the Center of Tissue Engineering, I'm working with the PhDs in stem cells and a whole lot of different things there. From a cosmetic sort of perspective, and I hate to use that term because it's really biotech that we're doing now. It's gone to the level that we're when we talk about skincare, it's really not that anymore. It's pretty close to pharma in what we do and the way that we actually investigate these. So really, in the early days, I started off as a plastic surgeon doing plastic surgery procedures. But as most plastic surgeons, you start off with quite a big reconstructive bench, and those are the sort of areas that you were talking about in those papers. So yes, you're right. Let's see, how do we combine. So firstly, we start with reconstructive. So I did a lot of hand surgery. So there were a lot of different what we call replants. If somebody cuts their thumb off or their finger off, you put it back and you do different things. And we even did limbs for limbs and a whole lot of microvascular surgery. That was part of the reconstructive element right in the beginning. Then it slowly evolves into more aesthetics. But before that happens, I sort of delved into, and this is one of the papers you mentioned, patients with colostomies. I saw this happening where patients have this colostomy from various disease processes, and they also put on weight, and they're also really uncomfortable related to the colostomy. And if they have a lot of excess girth or weight around there, it actually affects the evacuation of the colostomy. So it becomes a thing. So I said, well, okay, let's put our heads together from aesthetics, where we're doing tummy tucks and what we call abdominoplasties, and see how we change the pattern of things to match the patient with colostomy, to see if we can tighten the muscles, tighten the skin there, and that will give them sort of extra evacuation capacity. In other words, the functionality of it. So instead of sort of changing their bags, so many times a day, you can decrease it. And I guess what I'm getting at is there is an area where there's a merging of this reconstructive and aesthetic field, and that was pretty interesting there. And also, I must also mention that every reconstructive procedure that you do has an aesthetic sort of objective to it. What you're trying to do is improve either mostly sort of the appearance, bringing people as close to normal as they were, before on the reconstructive side, but then also looking at functionality in different areas. So plastic surgery is one of these fields that is just so incredibly wide-ranging. We deal with everything from head to toe. So the anatomy, you have to know your anatomy of every part of the body. You can literally work in the bowel. You can work on hands. You can work cerebral, areas. So you're working in a whole lot of different areas. And when people talk about plastic surgery, of course, the first thing they think about are, facelifts and the different areas there. But that's just one small facet. There's also burns, there's congenital, there's hands, there's pediatrics. So there's a huge amount of different areas here. So that's what drew me to plastic surgery in the first place. Was very involved in, as I say, the reconstructive first, then I went on to aesthetics. And I practiced in South Africa for 20 years. And then for various reasons, mostly security-wise for children and things, I was concerned about their security. At that level, we made the decision to emigrate. And I'd already had quite a lot of contact with the United States. I had green cards on an academic merit basis. And I am a fellow of the American College of Surgeons, so I had that capacity. But it also gave me a unique sort of start to say, okay, let's see, instead of retiring, let's rewire and see if we can get into another area. I've always loved research and been involved with different companies in South Africa with research and wound healing. Can I sort of tilt a little bit towards just doing research now? It's been fantastic. I've loved what I did with plastic surgery and looking after patients, but maybe I can contribute more by looking at the research elements that were there. So I've given you a really long answer, but that's the sort of background of the whole story.
No, it's an awesome answer, and I appreciate that, Alan, you going into all that. It's quite interesting because right around the time that you make the transition from South Africa to the West Coast here. You wrote a really interesting paper. It was December of 2008, entitled "Multimodality Scar Management Program," and it's sort of based. Actually, it's work that you did sort of the entire decade before that, and its culmination. And the thing that was very exciting about this, and this shows up not just in your skincare work, but a lot of the stuff that we're going to be getting into broader in sort of tissue engineering and regenerative medicine. Um, you're not afraid of moving away from sort of the single magic bullet concept that we had coming out of the pharma industry, a little too much of, in the sense that here, particularly in this paper, you talk about, look, there's scars, but there is inflammation going on here. There is hydration. There is the proper maturation of collagen. There's all this interesting biophysics happening in the domain of the scar that we have to think about. This is not just, a single approach. Talk a little bit about this work, if you would, and how this sort of the genesis of your thinking broadly in regenerative medicine, that these combination concepts are going to be required in understanding how to properly regenerate these types of tissues.
Yeah, I think that's a really perceptive question, because you've dug into the sort of philosophy of this, which goes deeper than just the scars, which we'll talk about in a second. But excuse me, for me, the real answer to so many of the problems that we have now is a synergy of different areas. So if you're using a device and using a topical and maybe even a systemic, the results of the cumulative story of the advances that we've had in the last couple of years in terms of genomics, in terms of biomedical engineering, in terms of a whole lot of areas of fascination that are really synthetic biology, a whole lot of things that are really built and grown. If you start putting those all together, the real advantage of synergy is there. So if we look at scars, so that's a different sort of story. And multimodality comes up a lot of times. Is I'm saying, okay, let's look at this. Even with pigmentation, I've said, guys, we focus too much on one particular pathway, one particular cell. Let's look at a whole lot of different things. And with scars, one of the things that I started looking at really early on, if you remember when CABG, the cardiac bypass surgery, was so popular, one of the worst problems was really the scar, the sternal scar. Compared to anything else, the chances of that scar thickening and causing hypertrophy were just so much greater than anywhere else. And I started looking at this and said, okay, let's see what the sort of the little special areas or nuances are to this pre-sternal scar. And we discovered, pretty early on, that it was basically related to the physical parameters that you mentioned, in that there were vector forces. There were vector forces that were actually working in so many different directions. If you think about the front of your chest, there's movement going on all the time from your neck and your head. Every time you move your arms one way or the other, you're pulling on it in all different directions. And this sort of directional pull, when you have a raw scar or a new scar, what happens is the signaling that takes place inside the skin level that says, hang on, somebody's pulling on me. It's going to burst the scar open, make more collagen, make more scar tissue. And it thickens up as a sort of coping mechanism to stop it from bursting open. And this is especially true in the pre-sternal area in the front of the chest. So we said, okay, well, if that's true, the first policy that we need to look at with the scar is support of the scar. Is there something else that we can do where we're helping out that signaling mechanism? We say, don't worry, we've got you covered. We're going to splint the scar. And the very first basic story that still a lot of people are using is MicroPort tape. Is just stick some MicroPort tape on there. And in the beginning, a lot of people used to put steri strips and things across. That's not the right way to do it. Put it longitudinally along there. So what you're doing is actually giving it scar support. There are a whole lot of more sophisticated devices since then that have come out. But in fact, MicroPort works pretty well. And why I love MicroPort is because the support is one thing, but then there are other areas that I'll talk about in a minute. But with MicroPort tape, you can take the topical, you can put it on top of the tape. Because it's porous, it's going to get absorbed through there, and it's going to work as a slow release mechanism to try and influence the scar. So this support was the first sort of thing we noticed. The second was silicone sheeting was used a lot for scarring at the time, still is used a lot. But when you go into the basics of why silicone sheeting or silicone gel works, it's mostly on the basis of hydration. And we found that when you hydrate a scar, basically the signaling mechanisms, what we call the cytokines, these inflammatory sort of reactors that are elaborated that will stimulate new collagen formation, it almost gets put to the fire gets put out by using hydration on the top. So we said, okay, we need to combine something where this scar is hydrated and kept moist so that you don't get the sort of drying out as well. And the next one was really looking at how fast can we mature the scar. Because when you look at scars and they're immature, they're usually red, they can be purple, they're very reactive. And in that state, if you start pulling on it or doing something where it's unnatural, it's going to thicken up tremendously. If you look at a scar that is mature, it usually has a white color. And that white color means it's mature and it's very unlikely to change from its current sort of position. And we want to try and say, let's get from the red to the white as quickly as possible. What does that mean in biologic terms? It's usually that you're taking the ratio of collagen 3, which is an immature collagen, to collagen 1, which is the mature collagen, and you're trying to get to that collagen 1 as quickly as possible. So we study different products and botanicals and different things that would actually stimulate collagen 1 and get us to maturity as quickly as possible as well. And when you start putting all those together, you support the scar, you hydrate the scar, you get it mature as quickly as possible. You use micropore tape, you take these different agents and you put it on as a topical. That all comes together as a multimodality way of actually maturing that scar and ensuring it. And then we went through a whole lot of clinical trials. And yes, you're correct. I did most of that in South Africa. And in fact, my first couple of years here, aside from the academics that I was involved in, was really sort of going around the country and sort of seeing which companies would be good for me to license that technology to. And that's how I met a lot of people in the industry. So eventually I licensed the technology to SkinMedica, and they still have this today with scar recovery gel. And then they were acquired, as you know, by Allergan. Allergan was acquired by AbbVie. And I mean, there's, this whole sort of, I call it 6 degrees of separation because everybody knows everybody, but it's a real hub of an industry there. So that's how that evolved. And that was the first real move that I had in the States in terms of introduction to a whole lot of people that moved me on to my next step. But while all of that was going on, I was lecturing at the university, and I got to know people there. And eventually, the chief of plastic surgery there, Greg Evans, had a meeting with me and said, "I know you want to use our lab. I got one better. Won't you sort of take over the lab and sort of look and see how we can get things together and develop them?" And that's what I did. So in 2012, I sort of got knee deep into it, started things again there, and that's also been a beautiful trip that we can talk about.
Absolutely. Yeah, no, I'll get to that one after this next piece because there's one other aspect of what you were working on those years in terms of 2011, 2012, because, and again, this is, I really find the type of work you did quite elegant. And I'm referring here to 2 papers, one on extracellular matrix. So, a lot of interest in ECM over the last decade. And, this understanding that we are a lot more than just our cells, that there's this complex set of networks between the cells. And in this one paper in 2011, you talk about this principle of dynamic reciprocity. We need to think about not just cells, but matrix and all the wonderful signaling that's occurring, whether that's biochemical, biophysics, and so forth. And then the very next year, this really interesting paper on this principle of catabasis, I'm pronouncing that properly, looking at, okay, we have inflammation. We know this is a bad thing, but too often it's primarily been focused on by the steroids and the non-steroidals. But you're pointing out, no, there's quite a few other things happening behind the scenes in terms of natural signals in our bodies, called stop signal mediators. Things like lipoxins and resolvins and protectins, and I'll let you go into that. Talk about these 2 areas because I think these are exciting, not just from the aesthetic perspective, but all of this is completely relevant to every other aspect of regenerative medicine that is hot in 2024.
You're so absolutely right there, and it's amazing that you picked on those two areas because it influenced so much of my. When I designed new skincare, again, it's peri-procedure topicals that I designed were really based on this whole, personally, the ECM, which for me was, I was talking about this yesterday. When you develop a new product, rather than as with is going on now with exosomes now is, it's just, it's the repair all and it does everything. Target. Say, guys, what's the indication? What am I going for? What's the target? And let's see if it's suited to that. And let's see what the cargo is that it's carrying. Now, the same story here is with the ECM. I decided really early on when I was introduced to the peptides that Elastin was interested in. And they said to me, why don't I write a white paper on it and see where it can go with it? And I said to them, listen, guys, I can write the white paper, but I want to know that you're going to be following up what I say and that there's a potential to actually take this into a whole new direction in terms of skincare and peri-procedure management. And if we focus on the extracellular matrix, that is really going to be important. And what did I mean by it there? And that's where catabasis and all this comes in, is that through the years, the one thing we discovered, and I was very involved, and I didn't talk about this much, but in South Africa, I was very involved with wound healing and a company called Smith and Nephew. And sure. Smith and Nephew had a dressing called Acticoat, which was nanocrystalline silver that was used for burns. And I did a lot of work with them on that. And I did a lot of work on different sort of wound dressings. And I had at one stage 13 wound clinics in South Africa. And I wasn't actually doing the dressings. I was doing the background science for the dressings. And we had wound care specialists that were doing the dressings. But that gave me a really good insight into wound healing, which I think is the basis of all the treatments and diseases that we use. It's so important in the whole sort of background. And that gave me a nice standing. Now, why is that important? Because, I watched the development, for example, of platelet-derived growth factor. In 1997, the FDA passed it for the use in diabetic foot ulcers. They approved it for its use. And we used it and we put it onto diabetic foot ulcers, and within minutes it disappeared. It was a waste of time. We said, oh my God, what's going on? I said, what's going on is that the actual wound itself is full of corrosive enzymes, inflammatory mediators. Catabasis is really high. You've got things going on with lipoxins that you talked about that are actually killing anything or any therapeutic that you put on there. What you've got to do is control the wound microenvironment and milieu before you apply any therapeutic. And from that came this whole principle of wound bed preparation. And they had an acronym called DIME or TIME, which said you've got to do debridement first, you've got to decrease inflammation, you've got to submit moisture to the wound, and you've got to encourage epithelialization. Then and only then should you apply your growth factors. And that's when they started having success with the therapeutics that they were using. So wound bed preparation became very important. And I put this all together when we were considering the skincare and the peri-procedure. And I said, okay, let's say the skin is a chronic wound. Why are we saying that? Because every day it's subjected to photo damage and all sorts of areas that are creating a potential for wound healing. In other words, there are aggravating factors extrinsically, most of which, 90% of which is photo damage and sun damage and the problem with UV light. And then there's also inherent aging that's taking place intrinsically that actually causes problems as well. And I said, if you look at those and you look at that as a chronic wound principle, then we need a skin bed at preparation before we start actually doing our procedures. And we need a kind of preconditioning of the skin before you do procedures, because if you do that and you clear out, like we did with chronic wounds, you clear that bed, that skin bed, then your chances of optimizing results are going to be that much better. So the first thing we had to do there was define, okay, well, if that's the case, we know what it was in chronic wounds that was collecting. What collects in the skin just related to this damage from the UV light and from aging? And we started defining this, and I said, let's particularly look at the extracellular matrix, the area below the epidermis, the dermo-epidermal junction, and then we've got the dermis, and the extracellular matrix is sitting here between the cells. Huge amount of signaling going on. There's a complete, so when we talk about dynamic reciprocity that we talked about before, there's a major amount of dynamic reciprocity going on between the cells and the proteins. And the cells in the extracellular matrix in particular are the fibroblasts. They produce collagen and elastin and hyaluronic acid. And the proteins are collagen and elastin mainly. And the fibroblast sits on the collagen fiber and their focal adhesion points, and they talk to each other all the time. But what happens with UV damage, and this is what we started investigating, is the UV damage actually breaks up the collagen and fragments the collagen and the elastin. And if it fragments the collagen and elastin, that fibroblast, which normally lies stretched out on the collagen fiber in a spindle shape and is very active, if you cut that collagen fiber, that chaise longue that it could sit on is not there anymore. And the fibroblast changes its shape from the spindle shape into a round-shaped fibroblast.
Okay.
And one of the things that we recognized in chronic wound care is a round-shaped fibroblast is a senescent fibroblast. It is sleeping, it is not producing collagen and elastin, but even worse, senescent cells, which is a major part of anti-aging now, actually produce what we call SASP, these senescent associated secretory phenotypes, which are really full of inflammatory mediators. So that's a very important part of the whole process. So, okay, let's see if we can get rid of this fragmented collagen and elastin, change the milieu of the extracellular matrix so that we get the damaged waste products out of there, and we pull in peptides that will stimulate new collagen and new elastin, etc. So this was the whole concept, and you've touched on both those areas, which are so important to this evolution of this new concept that nobody had talked about before. And that's take the extracellular matrix, look at, and I say, if you want to sort of summarize what we do very briefly, we're in waste management. It's the best place to be when it comes to diseases. Because when you think of, Alzheimer's and tau protein and beta amyloid, and you think of Parkinson's and reactive oxygen species, and you think of cardiac disease and atheroma and plaque formation, these are all waste products that are part of the disease process that creates so much problems. And if we can get rid of those, and the same thing holds for the skin, can you get rid of the waste products that are developing there related to the UV damage, etc.? And we found, yes, by doing combinations, and this involved a whole lot of gene expression work that we can talk about later, but we identified these powerful peptides that could clear that extracellular matrix, that would stimulate new collagen and elastin, and would create an atmosphere in the extracellular matrix so that when a procedure was done, the signaling now became clear, that the fibroblasts knew what they had to do, and it optimized the outcomes and the actual experience of the procedure. So that was one huge major new area that we developed that became known as preconditioning, extracellular matrix remodeling. We looked at autophagy because that was part of the whole waste management program. So it became a really nice, I talked about the waste management being the fragmented collagen and elastin, but there's a lot more. And as you know, glycation in products, when you start over the age of 35, blood sugar, if you start loading with a whole lot of blood sugar, you get this Maillard reaction, which is a reaction between the proteins and the aldehydes of the sugar, and you get the stickiness in your vessels, but you also get the stickiness in the extracellular matrix. So getting rid of that. And so there's a whole program that we looked at in terms of let's get rid of those waste products. And that was based on what you perceptively picked up on very early research that I did on this dynamic reciprocity in the extracellular matrix, how it works and functions best. And then secondly, catabasis is let's look at the inflammation and the background inflammation, which is so important in terms of trying to douse and to control that, because regeneration can only take place when you control inflammation.
Yep. No, it's very refreshing hearing all this, and again, thinking about the way you think about things in terms of sort of this combinatorial approach to, what really is going on here, and how can we create interventions, whether they're a drug, whether a device, biologic, that ultimately recapitulate proper forms of regeneration. So that's really exciting to hear. Alan, one of the interesting things, in looking at CTE in terms of the Center for Tissue Engineering, you're involved in quite a broad range of, it's not just obviously wound healing anymore that you're doing there. Wound healing is part of it, but again, you're involved in cartilage formations. I saw papers on peripheral nerve regeneration. You studied ischemic reperfusion injury, and again, aspects of the microenvironment there. Take us a little into sort of the day-to-day of the Center for Tissue Engineering, and a little bit about sort of how you because I know you're involved in the device development, but I also see, as you mentioned, you work with the adipose stem cells, stromal vascular fractions. You're working with everything as well. So talk about sort of what the day-to-day is about and what type of collaborators you have, because clearly, from nerve regeneration on one day to cartilage regeneration, there was a project in here on pancreatic islet cell survival concepts. Um, Talk about CTE and sort of your day-to-day, what that.
So in fact, this is really the hybrid that I was talking about, and why I consider myself so fortunate and to be, so stimulated across so many different things. So at the Center for Tissue Engineering, really what we're looking at is the sort of moonshot kind of projects, really looking at these that are a little bit more complex, that are going to take a much longer amount of time, that are going to involve FDA down the line,
Yep.
but are pretty groundbreaking in terms of what they can evolve to. So from that perspective, we looked at a couple of areas. Firstly, as a plastic surgeon, obviously we looked at areas we're saying, what's the need out there? Where are we actually deficient in terms of the results? One of them we looked at was ear reconstruction and said, the poor kid has to go through, if a child is born without an ear or only part of the ear, you do an ear reconstruction. Mainly that's using part of the child's rib. There are a whole lot of other areas, but the main sort of ear, or let me say, there are a whole lot of different reconstructive options you can use, from a artificial ear right up to using a framework that is synthetic. But all of those have their own problems. So you'll find that a huge amount of reconstruction is done based on taking tissue from that child who's 9 or 10 years old. You're taking ribs out there. That's not a pleasant kind of story. We are sort of fabricating the rib into a shape and then putting a skin flap over, or a skin graft over that, and trying to shape the ear. It's a very, very taxing sort of problem in terms of the actual creativity of it, and some surgeons have it right, some don't, and the end results are not always what one would want, and the child goes through a significant amount of morbidity. So we said, okay, let's look at this. And it really started off from the perspective, you talked about adipose-derived stem cells. The one advantage we have being affiliated with a plastic surgery department is we can get stem cells from liposuction. So patients that undergo liposuction, we can use what we call lipoaspirate, and we can actually take those adipose-derived stem cells. And we discovered really early on, and in fact, Pat's looked at the work at UCLA very early, and we collaborated with Pat as well, in identifying that there are adipose-derived stem cells that are really, at the beginning we thought bone marrow was everything, the only stem cells we could get. But adipose became this really good area to take it. You don't have to go into the bone and take it. Patients that are having liposuction, you can actually, isolate the stem cells from there. And we found that they had very, very powerful regenerative properties in a lot of areas. So you can train those cells. The stem cells mean that they can change into various, different types of cells, or different types of tissue. And one of those tissues is cartilage, one of them is bone, one of them is fat, and some of them are nerves as well. So those 4 areas, you can actually train or change those adipose-derived stem cells to change into those kinds of tissues. So that sounded great in the beginning, and okay, now let's just create this whole factory of different tissues, and we can use the adipose stem cells to do it. And very soon we realized that, hang on, this is not how stem cells work. When you actually put a stem cell into the body, what it does is it actually stimulates the host tissue to produce their own kind of extra tissue and things. The stem cells remain there for a very short period of time. And it's really the paracrine effect. In other words, what the cell secretes that's influencing the host tissue, rather than the actual cells changing into other tissue. Only a very small proportion of them differentiate into other tissue. And that was a lesson that we learned really early on, a lot of different scientists, that, hang on, this is not just a matter of injecting stem cells in there and watching them generate new tissue. It's that they're going to have influence on the host tissue, and the host tissue are going to generate new things. So we looked at cartilage, so adipose-derived stem cells and cartilage formation. You have to have a basic framework that you're going to use, and various different hydrogels and background different materials we used as just a scaffold. Is okay, now we've got the scaffold, what cells do we use? So if you're doing cartilage, the obvious one to use is chondrocytes. And then we started looking at chondrocytes and said, by passage 2 of chondrocytes, by the time you actually try and get a whole lot there, they're getting really tired and they don't want to produce any more cartilage, and they don't want to proliferate very much more. So chondrocytes are really not doing the job on their own. They're never going to populate this framework very well. Let's try and actually mix them and add the adipose-derived stem cells to the chondrocytes, see what happens. And lo and behold, we found that the chondrogenesis, the formation of cartilage, was really stimulated very nicely. And we worked out a proportion that we got of 9:1, that if you have 9 adipose-derived stem cells to 1 chondrocyte, we're really producing some good quality cartilage from there. So that became the cellular menu. And then we used a whole lot of different fabricated frameworks to look at that. So that's still work that's ongoing, and we're doing different areas there. But the end result of that is we're hoping to be able to take a patient's tissue that they usually have a couple of sessions for ear reconstruction. The first one is just taking the little lobule that may be there and shifting it a little bit and working out where you're going to put the ear. But while you do that, you can take a tiny piece that sometimes have a remnant of cartilage, and you can take that out, and we can take a little bit of fat out. And from both of those, from the patient's own tissue, we can create the cells that we need from the adipose-derived stem cells from the fat, and from the chondrocytes from the cartilage. And in the lab, we can actually, once we've decided what's the framework we're going to use, we can create that whole framework. We can seed it with cells in there. And what we're hoping to do is then be able to use that to put into the child without taking their own, cartilage and things. Mm-hmm. So that's that project. And then we've done a number of different projects, again, related to adipose-derived stem cell. But we've really dug down. I would say that now we've got a primary focus, and that primary focus is on fibrosis. And we talked about scarring a little bit before, but I've got a sort of adage that I've put up in the lab: all roads lead to fibrosis, because when you look at disease processes in almost every single organ in the body, fibrosis is part of the pathology that takes place there. And we found a way, which is fascinating, that if you take some adipose-derived stem cells, what we can do is we can change scar tissue into fatty tissue. So in simplistic ways, that's the easy sort of explanation for it. What happened is we started noticing when surgeons were doing fat grafts, and they actually did a fat graft under scar tissue, the scar tissue tended to soften and tended to change its nature. So that's interesting. What's happening here? Right. So we sort of got into that and dug into that, and we discovered the adipose-derived stem cells themselves had a direct effect, and that we could convert. And now we've looked at various growth factors, and we're trying to really dig into what is the thing that's actually converting what we call myofibroblasts, which are the scar tissue fibroblasts, into adipocytes, which are fat cells. So if you can imagine that patients with burns, you can have this recipe now and change the scar tissue into fatty tissue. That gives them a nice sort of area of cushioning now, which is great. And we're working on one particular disease process now as our sort of representative of that, and that's called Dupuytren's disease, which is a disease that affects a lot of patients where their hands curl up, their fingers curl up, and they're sort of stuck in one position. And that's because there's this overexplosion of myofibroblasts in the area. And we found a way now to convert these Dupuytren's myofibroblasts into adipocytes, which are fat cells. So that's, there are a whole lot of other projects going on, but really our focus has been using these adipose-derived stem cells, working out how do they contribute to vascular genesis. Okay, can we change scar tissue? Because that's going to have a huge effect. And most of that focus is around the adipose-derived stem cells. We have PhDs working there, and I have fellows, which is really fantastic. Every year we get, and these guys work salary-free for a year or two just to get the experience there. Fantastic guys, usually stop their medical school training, do 1 year or 2 years of research with us, and very turned on and very stimulated. So it's a beautiful environment to be in on that side. It also keeps my ear on the ground of what's going on in new development and new things happening. And then the other hybrid, of course, is my work that I do with Alastin and Galderma. And after the acquisition of Alastin by Galderma, I became the chief scientific officer of Galderma. So my sort of playpen increased substantially from that time, because now I'm dealing not only with the cosmetics and the peri-procedure, but I'm dealing with aesthetic injectables and prescription and a whole lot of different areas.
No, that's I appreciate the whole background of CTA and that last part about the sort of the trans differentiation dynamics that you're seeing there per the adipose stem cells. But that itself is just such a hot area broadly in regenerative medicine now, and it's nice to see that you're seeing some of that as well. Yeah, I mean, again, I guess it's a nice transition point because you mentioned sort of Alastin Galderma. Before, you talked about sort of fibroblasts, senescence, and SASP, and all that, and aging has been a pretty hot topic for us in recent years. In August of 2022, Journal of Clinical Aesthetic Dermatology, you wrote this really interesting paper on some interesting formulations that you were working on at Galderma. And the formulations aside, I mean, I think that's cool in its own right, but what you did here in terms of looking at things like telomeres and clotho gene expression and FGF and FOXO and all that stuff, these aging related genes, as well as ECM changes, things at the tissue level. I think you have a really interesting, that's not just an interesting story in its own right, but an interesting playground, let's say, because it's very tough for others in the longevity aging space to do things like this. It's very difficult to play around and check the age of a liver or a heart or the brain. But skin, in this case, offers you a really interesting sort of playground to understand things at the gene level, the cell level, the tissue level. Talk a little bit about this work and just a little bit about aging in general and what you sort of see as some of the next steps here in sort of the development of these types of technologies.
Yeah, no, absolutely right. And essentially that paper, to be honest with you, we write so many papers about clinical trials and wrinkles and fine lines and all this. And, I really wanted to do this sort of deep dive, which we do with every sort of product. So before I bring out any formulation, I do the first paper is a scientific paper. Okay, what have we learned? Where's it working? How's the gene expression? How's the ex vivo? How's the in vitro results? What are we doing? How did I get to this formulation on a scientific level? So don't even worry about the clinicals yet. And then the next paper is the clinical trials on it. Right. So with this, with the anti-aging, one of the maintenance stories of our restorative skin complex was that we're looking at various areas of skin rejuvenation. And so there's moisture and there's all sorts of things. And one of them that I looked at is fat. And that's another whole topic on its own, because in fact, I'm writing a paper now that's talking about how fat got a bad rap, and it's probably the most regenerative organ in the body. When it goes bad, it's really bad. But when it's working well, fat is incredibly regenerative. So we just sort of mentioned a few things now with adipose-derived stem cells. But if you can actually stimulate new, good, young, fatty cells, it's going to have effect all over, including skin health. So with this paper, I really said, okay, let's do a deeper dive into, as you say, longevity and anti-aging, and cellular longevity is a big thing. So the first thing is telomeres. Our telomeres shorten as we go on, and there's a sort of lifespan that you have with cells. And as the telomeres shorten, you have less of this sort of lifespan. Well, let's see if what we're using in our formulations, we've got antioxidants in there, we've got a whole lot of things in the formulation. Does that actually affect the telomeres? So we sent that off. There was a company in Spain that were really very good at doing telomere measurements, and they did that for us. I said, okay, that's on the one side. On the other side, there's been a recent sort of, at that time, there was a recent evolution of this, or discovery that this clotho gene, they called it an anti-aging gene, that in fact, if you could stimulate the increase in this, the KLOTHO clotho gene, that was very representative of an anti-aging gene. So again, I took what we call our TriHex technology, which was this combination of peptides, and I said, okay, well, let's do gene expression tests and see actually if we stimulate them in different cell lines and what the CLOTA gene is doing. And we saw that we stimulated that. Then we added a whole lot of studies, clinical studies and biopsies, and we put it all together and said, in terms of maintenance, yes, we've been looking at fine lines and moisturization, but actually there's a lot more to it going on here. We've got an anti-aging cellular longevity story that is so important to the whole concept, that is additive to the just, what you're looking at from the appearance. So that was really that focus there. And we've sort of continued with almost every formula. It's not almost every single formulation before I think out what it's going to be. I say, what is lacking in the current market now? And I can give you an example on any one of ours, whether it's pigmentation, whether it's our hyaluronic acid preparation, whether it's our antioxidant, every single one of those, we've taken a different approach in saying, okay, people haven't thought about this. Let's look at this as a different sort of pathway and see what we can get out of it. And that's paid huge dividends for two reasons. Number one, obviously, the end results have been great. But number two, when I get my colleagues excited, there's nothing better than having guys than physicians. We're in a professional skincare sort of area. So that our products are purchased by or worked through the physicians' offices. So you've got to be able to present that physician with something that he or she is excited about and that they get turned on about. And then, that becomes a real good motivation.
Mm-hmm. Mm-hmm.
I can't remember if I answered your question, Ira.
No, spot on.
Okay.
Spot on, definitely. And again, that paper echoed again, not just where you've been and your thinking, but again, this is a new area. It's still whether it belongs solely in the hands of pharma, or whether it's in this particular case the cosmeceutical space, because there's things that cosmeceuticals can do in terms of combination approaches that aren't that easy in traditional pharma. But I know that it was spot on. And I wanted to ask you about one other paper, and then we can sort of go into what's happening in the future. But that was May of this year in Journal of Drugs and Dermatology. You wrote a very interesting piece entitled "So Let's Design a Peptide: A Physician's Approach," and basically it's sort of a step-by-step plan for maybe physicians that are unfamiliar with sort of pharmaceutical development and everything that goes on there, but obviously are very good physicians, dermatologists, and what have you, how to think through crafting sort of a novel intervention. In this case, this is specifically your work on how we develop interesting peptides for extracellular matrix dynamic reciprocity biology. Very important, very hot area, of course. Why did you write this paper? And talk a little bit about sort of what your thought process was in sort of teaching.
So a couple of reasons, Ira. It's actually quite funny because what happens so often is when I give these talks to physicians and there's always one or two guys in the audience that are keen on developing their own product or doing something themselves, or I don't think they quite understand how big a project it is. But that said, I also wanted to say to them, guys, if you put your mind to it, and if you don't sort of dig too much into, I can never do this, I haven't got the knowledge about this, but you take it step by step, there's a possibility that you could come up with something that really does score. And that's what happened with this particular story. Is I said, okay, I'm dealing with the extracellular matrix. What are the proteins there that are important? Elastin is my main sort of story, because elastin is really a regenerative protein. You don't see elastin in the face of inflammation. It's only going to form. And in fact, when I started, my derm friends and colleagues said to me, listen, you can't regenerate elastin. It's one of those things that doesn't regenerate. You get a certain amount, it disappears, and you can't. And you've got, we disproved that completely. And then we showed, and when I did stains at first, they said, yes, but that could be bad elastin from solar elastosis. Okay, we developed new stains, and we used new stains that showed new early formation of elastin protein. So that we got straight. But when you look at collagen and elastin, which are the really two important structural proteins in the extracellular matrix, if you analyze and this is what I did, I looked at the amino acids, and I said, okay, well, what are they made of? And I looked at this and said, oh my God, 75% of these are repeating amino acids. It's the same amino acid all along. It's these three amino acids that are repetitive, and every now and then you get something different. So let me take those 3 amino acids. I'll add a different kind of amino acid in between, and I'll play around with a whole lot of different combinations. And I found a software program that I could plug this into to see if, firstly, it was stable. Secondly, that the molecular weight, it was important to have something around about 800 Daltons so it could get through the skin, which was okay. And then thirdly, look at, see, has this been described before? Let me do an IP search about it. And so I'm cutting it short, but really what I did was it had an aha moment and said, God, most of these things are just repetitive. It's the same amino acid. I'm going to take those 3 guys and I'm just going to shift it around a little bit. And I got to an octopeptide, an 8 amino acid story with 2 repetitions of the 3 is 6, and then put, something in between. And I got this and developed it, and we did the whole story, and I started doing gene expression, and I couldn't quite work out where it was working. And that was in 2017. And around about 2019, I was working on our HAMS, which is our hyaluronic acid product. And I was extremely keen on developing a product that only had high molecular weight hyaluronic acid. And again, I'd learned this from the wound healing literature. We knew that if you used low molecular weight hyaluronic acid, it was pro-inflammatory, that it created inflammation. It was there as part of the breakdown when you have wound healing, and hyaluronic acid is broken down into low molecular weight, and that's part of the initial inflammatory sort of process where you bring in inflammatory stimulation, etc. But when you're doing skin maintenance that is not really, you don't have a wound per se. You have a theoretical wound, but you don't have an open wound that needs sort of closing. You want a high molecular weight, not a low molecular weight. Low molecular weight is pro-inflammatory, high molecular weight is anti-inflammatory. So I was trying to create an anti-inflammatory hyaluronic acid. And while I was doing this and doing gene expression on a whole lot of different products, seeing the fibroblasts, what kind of hyaluronic acid, or seeing if they could get a topical that was producing hyaluronic acid, I've added the octopeptide 45 in there. And really, it took me completely by surprise, but it blew hyaluronic acid. It got it to wonderful upregulation of genes related to it. And we went right down the pathway. We did a whole lot of gel diffusion experiments and all sorts of things to see what's the size of the hyaluronic acid that was produced by these fibroblasts. It was greater than 2 million Daltons, so it was a really nice high molecular weight. So that became really great, and it became the focus of this octopeptide 45. So everything came together there in terms of, I found a way based on a very simple sort of formula of taking the amino acids that I saw commonly, adding a couple together. And you'll see at the end of the paper, I quote Yogi Berra, and I said, it's better to be lucky than to be skillful. But, in this particular case, I think there was a lot of luck involved in that. I didn't really have the background for it, but it did work out just by following those different steps. And I thought, well, let me share with the guys, what goes on. Yeah. Also, so that they understand why I've added octopeptide 45 to a lot of these formulations, because the hyaluronic acid that's stimulated is so beneficial to so many different areas related to that.
Absolutely. No, that's, again, a fascinating piece of work, and I appreciate you sharing that and the background of it with us. And what's coming up for the rest of 2024 as we get into 2025? Whether we're talking about CTE, your role at Galderma. Obviously, I saw that you were sort of on the conference circuit quite a bit this year in terms of the dermatology summit, the aesthetic technology forums. What's coming up? What should we know about in terms of exciting things? What you're excited about in terms of the derma cosmeceutical space, the derma pharmaceutical space, and anything that we should know about that I have not touched on beyond the slew of topics that we've been going into today?
Yeah, so I mean, there are a whole lot of different formulations, but the latest one that I'm most excited about is our antioxidant, which was the C radical antioxidant. And again, that really came about because of, completely by just delving into the elastin science. Yeah. And that's elastin, not elastin, not to be confused with the company name, but elastin, the protein. When I started digging around in the cardiovascular science and discovered that there was, with our major vessels, there's a lot of loss of elasticity. So they're very interested in elastin as well, based
Yeah.
on those changes. So I came across a story where they'd used ascorbic acid. Of course, vitamin C is the backbone of antioxidant sort of therapy, has been used forever and ever.
Right.
And basically, there are a lot of really good antioxidants, but vitamin C remains in the minds of physicians as the antioxidant. But what I discovered was the L-ascorbate form of vitamin C appeared to be, or should I say, tropoelastin, which is the major protein in elastin, seemed to be very sensitive. The mRNA of tropoelastin seemed to be very sensitive to L-ascorbate. Nobody had ever looked at that. Because when you think about vitamin C, everybody thinks about collagen. So, okay,
Right.
yes, we know it's stimulating collagen, scurvy, we know the whole story with that. But nobody's looked at elastin. And I found L-ascorbate, which is traditionally used in almost every antioxidant. Hang on, it's actually not that friendly to elastin. So we started doing ex vivos. And the one thing I didn't mention to you, which is really when you talk about the future and what's exciting, is I get some of my plastic surgery colleagues to donate to me the facelift skin that they actually excise during facelifting. And we use that as an ex vivo model because
Yeah.
all the ex vivo skin models are
Sure.
usually from abdominoplasties. Why? Because they get a big area, so they've got a lot to use. That's cheaper for them over that area. But for me, this is not sun damage, photo damage skin. So to take facelift skin and use that as our model is absolutely ideal. So that's what we do have. And we've got other labs that we work with doing this. So all those gene expression studies that I talked about and all those other, ex vivos are done on this basis. So we had this ex vivo model that we could use as the basis of our sort of discovery there. And we started testing these different formulations, different ones with L-ascorbate, and then we started looking. They had suggested that the sodium salt, the sodium ascorbate, does not have the same effect on elastin. And when we started testing it, they were right. In fact, we saw that there were different changes in the ex vivo model. It was a little bit moth-eaten on the elastin related to the L-ascorbate, but on the sodium ascorbate salt, it conserved it. Anyway, so to put a long story short, we put this all into a formulation with sodium ascorbate and another compound that I use with a whole lot of antioxidants, including one of the compounds called lactoferrin, which I won't go into now, but we use that a lot with our pigmentation. It's a plasmin inhibitor and a really great molecule. And so we did all the studies, we did it out, and we did the clinical studies, and we biopsied 5 patients just out of randomly biopsied 5 patients. And when we looked at the elastin, 5 out of 5 were incredibly stimulated. So we thought that the sodium ascorbate was just going to actually conserve it. And all the literature would suggest this just conserves elastin, but something else was going on here. We were stimulating elastin. So I went back and I looked at this and I said, I think it's a combination of the lactoferrin plus the sodium ascorbate. And we did this and we did this other ex vivo model and found that this was the sort of combination. And, we used the IP for that. But that was a great discovery because now you have an antioxidant that stimulates collagen plus elastin, which is a really nice positive. So where we're going in the future, we're going to new areas that have not sort of been looked at in the regenerative field.
Okay.
We're lucky that we have elastin as a protein biomarker that we can use to test, is regeneration taking place? If elastin is being stimulated most of the time, it is. We have biologics that are really interesting. Exosomes have come into their own now, but I don't like the current form of exosomes. I think people have not examined the cargo carefully enough. There's mRNAs, siRNAs, DNAs, lipids, proteins, a whole lot of things in those exosomes that haven't quite been defined well enough. I think in disease processes, it's going to be fantastic as long as we've got the right delivery mechanism for it. But I think in skin health, we've got a much more targeted approach with peptides, and it's much easier to understand. And if you're doing a procedure, you have to put a lot of preservatives into this to keep it biologically active. And preservatives do not do nicely on the skin. And we see this in our ex vivo models. So these patients are really, it burns, it's unpleasant. And then at the end of the day, you're not quite sure what are you achieving with it because you don't know what the cargo is. When you're using peptides, you're really nicely focused there. So when you say what is the future, number one, it's going to be synergy. It's going to be devices plus topicals plus maybe systemic. Put them all together, you're going to get much better results with it. Number two, it's going to be with AI generated. And it was just announced last week, really exciting, that L'Oreal bought a 10% sort of share in Galderma. And L'Oreal's our big sort of competitive, traditionally our competitive company. But really, the discussion came up from L'Oreal, and this is what we're doing now, is, guys, what R&D can we do together that is really going to further the field? Let's forget about this competition for a while, and let's put our heads together. Let's tackle some good R&D. So one of the suggestions I had there is let's look at some, AI-generated stories. Let's look at small molecules that are analogs to growth factors or to antibodies or to mRNAs, and see if we can come up now, because the AI is just pushing us and saving so much time in terms of identifying different chemical formulae. So it's an exciting time from that perspective. I think that the product development that we're doing is not going to stop. There are a whole lot of new sort of areas that we can look at. I don't want to create a whole lot of SKUs, a whole lot of different range of things that confuses everybody. I'd rather stick with where we are and create the next advance. And what is the next one? So, for example, that octopeptide 45 is going to be used, in a very advantageous way down the road. And I think that as the new science evolves and genomics and molecular biology and biomedical engineering all come together, there are going to be a whole lot of new avenues for us to explore, not to mention, least of all, as I did say, the AI, which is going to have huge influence on the way that we do things.
Yeah, it's exciting to hear you bring up things like AI, because as you were just mentioning, not just the developing the new stuff, but as you were just talking earlier about the vitamin C story, I mean, that in many ways sort of resonates with me as in this repurposing basket, that we forget about all the stuff that we've studied for A, but we've never studied for B, C, D, and E. Correct. And so that's extremely elegant as well. So I'm excited. I'm excited for you, Alan, and the company and everything that's going to be happening both there and at the Center for Tissue Engineering. So really, best wishes to you and both your teams, HEDCT and Galderma, as you move these types of programs forward. And I hope we can do a follow-up maybe next year to see where everything is going. For everybody, again, that's going to be listening to this particular episode of our show across the various podcast networks, or who will be watching along on our YouTube channel. Again, you've been spending time with Professor Dr. Alan Widgerow, Division Chief of Research, Center for Tissue Engineering, and Adjunct Professor of Plastic Surgery in the Department of Plastic Surgery at University of California, Irvine, also Chief Scientific Officer and Head of the Skin Science Center of Innovation at Galderma. Alan, I really want to thank you for taking some time out of your schedule to talk to us today, to sort of tell us everything you've been up to the last couple of decades. Thank you for everything you do on sort of the science and innovation front. And as we like to say on our show, thanks for helping to create a better tomorrow for many people via the types of technologies and products you're developing. A really great story, and I look forward to following up next year with you.
Thank you, Ira. It's been a pleasure to be with you. Thank you.
Great having you.